Good afternoon and thank you for joining us.
Good afternoon.
My name is Les Jones and I'm joined today by my colleague
Rebecca Dunstall. Hi.
Rebecca is our clinical lead and will lead the training session today. Subject is the promotion or the use of specialist seating to promote function and independence. The presentation today will be a mix of a PowerPoint and a practical hands-on demonstration of the application of the theory with some of our products and using a case study to justify how we achieve the outcomes that we talk about. If I just leave Rebecca to wander away there to load the first part of the presentation. A little bit of housekeeping. We are recording the session, so hopefully everybody's mic and camera has been switched off, and if you could leave it that way for the session, that would be great. If you have any technical issues, my colleague Jess is in the background. If you want to use the chat feature to post any query that you have, either technical or if you want to query something that we talk about as part of the presentation, that'll be great. If you have a technical issue with connecting or hearing us, what we tend to find works best is to leave the presentation and rejoin. It just seems to work. Just switch it on and off, basically. After the presentation, we'll send you a link to the copy of the, a recording of the presentation. Plus, we'll be sending you Rebecca's slides as well. So I shall see you in about 20-25 minutes. I'm just going to hand you back to Rebecca.
Thank you very much, Les. Get this for the full screen. Give me a second. There we go. So as Les said, what we're going to do is run through really the theory behind postural care, why it's important for function and engagement, what we actually mean by function and engagement, and then we'll apply that theory to the seating solutions that can help support that. If at any point we mention any terminology or any specific bits of information that you want to know more about, then please do use the chat function. 45 minutes an hour isn't a long time to run through such a complex topic, but we have lots of past webinars that might be beneficial and some booklets and so on that we could share. So if at any point there's a bit more information you need, pop it in the chat and we can help. Now, just to set the scene, posture underpins our ability to function, to protect our health and well-being. When we sit in destructive postures or if there's body distortion, it can have severe and life-threatening complications. And ultimately, quality of life of the individuals that we work with will be impacted. Now, 24-hour postural care, even though we're focusing on seating today, those of you who have been to our webinars before will know how passionate we are about postural care, about that full 24-hour approach and how seating fits into that. The chair's only going to be as good as the other equipment and other postures that are adopted throughout the day and night. But postural care is essentially fundamental to functional independence, and it's the holistic use of any technique that we use, such as individual programs, aquatic therapy, equipment adaptations, signposting, orthotics, everything that we do as clinicians to minimise postural abnormality whilst enhancing function. And this approach that aims to preserve and in some cases even restore body shape for individuals with movement difficulties. Body distortion isn't inevitable, and as long as we are proactive, identify risk and get the right equipment in at the right time, we can reduce the risk of those secondary complications happening. 24-hour postural care is always best done as a multidisciplinary approach that encompasses a person's daily life whilst respecting all those activities and interventions that will impact on posture and function throughout the day and night. Now, what exactly do we mean by function? Well, there's three different elements we're going to focus on today: functional movement, physiological function, and functional engagement. Now, functional movement is necessary for us to be able to participate in the activities that are important to us. It allows us to access our environment, to engage with the world around us, and is critical to independence and an important factor in living fulfilling lives. An important part of this is postural control, which is essentially our ability to maintain our centre of gravity within the base of support. Now, if we have supportive sitting postures, we can promote normal movement by inhibiting some of those abnormal movement patterns that we might see. So those of you who maybe work with complex disabilities, those with neurological impairments, maybe choreic movements in Huntington's, ataxic movements, extensor thrusting, those with spasticity and cerebral palsy. What we need to do is make sure that we address that lack of postural control to encourage that functional performance. That reduced postural control can also have a result on mobility and falls risk as well. We might see individuals sliding down or out of the chair or even falling during transfers. Generalized weakness from immobility and deconditioning can also increase that risk as well. So those of you who might be working in elderly care, or those who might be unwell for a period of time of being confined to their bed, where they become deconditioned, can be at risk. Now, falls can be devastating for the individual and for the wider healthcare system because of the cost involved with things like hip fractures and hospital admissions and then long-term care. Human costs can include distress, injury, loss of confidence, which will impact on their motivation to stay active because of the fear that could be involved, and an increased morbidity and mortality. So research has shown that staying active and encouraging that mobility can not only improve an individual's health, of course, but also their cognition, their confidence and their mood. And then we have pelvic stability. Now for seated posture, the pelvis is the foundation. It's the core that supports all the body segments and dictates what happens above and below. And we can only get that freedom of movement in the upper limbs once we have that effective stabilization of the pelvis and trunk. To get that to get that distal control, we need that proximal stability. Because an individual who finds it difficult to maintain their sitting balance may naturally seek to provide that stability through their upper limbs, which then means that the hands are unavailable to engage in task performance. And then the feet, are they really that important in sitting? In short, yes, they are. So those of you who might walk into environments where foot plates are being used as door stops or bookends, or maybe a 6-foot individual is using the same chair as a 5-foot individual and the feet are dangling. That can cause a real issue for postural control and pelvic stability, because we naturally seek that proprioceptive feedback at the feet. Stimulation of the foot sole can provide the body with that important information that it needs about its position and its awareness in space. If we feel unstable, again, we can lose that function at the upper limbs because we are seeking the support through there instead of through the pelvis and the trunk. It's also worth noting that even in sitting, we've got 19% of our body weight going through our feet. So we could potentially have 94% of our body weight just going through our buttocks and thighs, and then we're wondering why things like pressure injuries might be happening. So the feet are really important for posture and pressure. Now that functional movement is really important to protect the body structure as well and reduce the risk of injury. Movement is important for blood flow and for activation and lengthening of the muscles. Individuals in prolonged sitting, regardless of whether that's destructive postures or even if somebody's in this gold standard sitting position, if it's prolonged, it can result in pain, soft tissue shortening and even bony changes. So that's when we think into things like contractures and deformities, which we'll cover shortly. The next element we mentioned was physiological function. Now, the inability to maintain an upright sitting posture has been associated with a decline in health. Unsupported postures can cause physiological dysfunction and even premature death. So what we might see is those that we work with presenting with pressure injuries, recurrent respiratory infections, they might have digestive problems and then be at risk of hospital admission. So if we can achieve good sitting postures, we can increase the ability of the organs to work more efficiently and facilitate things then like respiration, swallow, digestion, and even circulation. Destructive sitting postures will cause things like organ compaction. So we can see in that image there the distortion that could be happening at the organs. If somebody has head flexion or maybe a rounded shoulder girdle, it can impact on lung expansion and affect things like eating and drinking safely as well. So we really need to think about physiological function to protect health. And then the last element we have is functional engagement. So if somebody is finding it difficult to sit out efficiently and comfortably, then they can become confined to their bed and the four walls of their bedroom and have the limited opportunities for socialising. Destructive postures can restrict them from completing some of those much needed psychosocial and psychological functions. So we can see a reduction in social interaction. It can impact on their self-worth and ultimately quality of life. So research has shown that those aged 80 and over are twice as likely to report feelings of loneliness. And those feelings of loneliness have a strong relationship with low personal well-being ratings. And loneliness and social isolation, believe it or not, are twice as harmful as obesity and as obesity is to physical and mental health. So what we're trying to achieve through postural care is this stable upright position to encourage that participation in social activities, whether that's at home, school or work, and as part of the community. So encouraging that functional independence and participation. And that could involve their occupation as well as hobbies and so on. We need that head control to be able to orientate ourselves, to socialise and to develop communication skills. And also an upright sitting position for that better line of vision for interaction and to be able to complete cognitive tasks, which we know are precursors to improved learning and participation. So those of you who might work with individuals with cognitive impairments, with intellectual disabilities, dementia, trying to develop cognitive skills or try and reduce the risk and the speed of deterioration as well is really important to think about that postural care. So how does specialist seating fit into this? Well, specialist seating is critical to an individual's quality of life. When we lose the ability to achieve optimum posture, whether that's through age, illness, disability, disease, it can have a significant impact, as we know, on health and well-being. And essentially, we're aiming to allow individuals who might otherwise have difficulty to achieve their optimum sitting posture. And I say optimum here, and not good or perfect posture, because in real life cases, when we're working with complex presentations, it's just not realistic to achieve that gold standard. But we still need to strive towards that optimum sitting posture, that fine balance between correcting and accommodating. If we can't correct, we still need to accommodate. Now, this list isn't exhaustive. Specialist seating targets all different areas of an aspect's life. But when we're thinking about function and those three key elements, what we're aiming to do is to promote pelvic stability and postural control, give individuals that security and a stable base of support, while still being able to be dynamic within that and reach outside of the base of support while still staying balanced within the chair. We want to encourage all the body segments to work together efficiently, to encourage that energy management and conservation. And we want to facilitate normal or control abnormal movement patterns that we might see that can impact on function. And when we have a look at the case study and some of the seating solutions, and become a bit more clear. So within our clinical practice, these are the kind of red flags and presentations that we need to look out for. And they could be an indication that somebody is having difficulty to maintain an optimum sitting position, and it could impact on their functional performance. So what we might see is the upper limbs clinging to the arms of the chair. We could see elbows digging into the corners of the chair. We could see slumping or leaning to one side as gravity takes hold. So it tends to exaggerate those asymmetries. Or we could see the upper limbs crossed across the body or lap. And then the common postural challenges, which we'll cover when we look at the seating solutions, are things like fatigue, poor postural control, pelvic instability, increased thoracic kyphosis and contractures. Now, fatigue can significantly restrict a person's ability to engage in daily life, as well as having that negative impact on them psychologically and socially. Unsupported posture causes fatigue by making inefficient use of the body structure. And then gravitational forces on top of that can make sitting really effortful for individuals with things like muscle weakness or deconditioning and abnormal muscle tone. If an individual is low on energy, then of course their function and independence can become extremely difficult. And then they can start using their energy uneconomically to maintain an upright position instead of putting that into engaging in activity. And the problem with fatigue is that because of the nature of gravity exaggerating those symmetries, it can be associated with quite significant postural challenges, things like increased thoracic kyphosis and pelvic instability that we're going to look at next. Now, the key here is to have an implementation of fatigue management strategies into daily life, because this is what will reduce the impact and the probability of that fatigue becoming a chronic issue. And then obviously, of course, energy conservation will make it easier for individuals to live a meaningful life. And when we look at the case study, you'll get an idea of how certain functions can support that energy management. Critical part of this is the chair setup, and probably one of those really basic initial steps that can be overlooked. Every chair has to be set up to fit its user, so we've got to support the posture appropriately, ensuring maximum contact with the support surface to distribute that weight as evenly as possible. The seating prescription and our subsequent setup has to be based on the individual's body size and shape. If it's not, then it can cause more harm than good. So things like seat depth and seat width are really critical to functional performance because it allows that pelvic stability and postural control. And when we look at the chairs, we'll give you an example of why it's so important. We could see individuals with a posterior pelvic tilt, so sacral sit-in. I don't know if you agree, but one of those most common postural challenges that we can come across, where the individual is sliding down the chair into that sacral sit-in. What we can see is increased shear and friction forces. We can see hyperextension at the neck because they're trying to maintain that visual field. There might be an associated kyphotic posture and an increased risk of pressure injuries then over that apex of the thoracic spine through the sacrum and the heels. When we talk about postural challenges, these will become apparent as part of your postural assessment, and it's really key that that's done before the seating assessment with the likes of Careflex seating assessors, because it will dictate what kind of chairs need to be trialled. So depending on the pelvic presentation, things like critical angles, and what the intrinsic and extrinsic factors might be will dictate what might be needed. So for example, somebody with a sacral sit-in, due to limited hip flexion, we may need a different prescription to somebody who has a posterior pelvic tilt because of weak abdominal muscles. One might need back angle crine, whereas the other one might need more trunk support. So it's really key to find out as part of that postural assessment what the causes are, so the seating solutions can be matched up when you work in combination with the seating assessor. You can have an anterior pelvic tilt, and then this can be associated, you can see in the image there, with an increased lumbar lordosis. Individuals can have a reduced functional reach because of the position and the attitude of the upper limbs. It could be because somebody has extensor patterns of activities, they're going into their extensor thrust, or it could be a conscious decision because if you're working with individuals with obesity, with bariatric or plus size individuals, they might be going into this position to relieve pressure on the abdomen. So again, that will dictate whether we correct or accommodate. Is really key as part of our postural assessment to find out the reasons. I might have a pelvic obliquity where one side is higher than the other, one side of the pelvis, you can see in the image there. And what we can then have is an asymmetrical trunk due to abnormal muscle tone, could be fatigue with gravity, or it could even be, again, a conscious decision for comfort reasons because of pain associated with hip problems, maybe subluxations or dislocations, and they do in it for comfort reasons to open up the hip angle. So again, do we correct or do we need to accommodate in those circumstances? And then there's also a pelvic rotation, which is often associated with the pelvic obliquity, not always. But then because of the nature of the pelvis being the foundation, we can start seeing spinal rotations then, that whole body effect that's happening because of what the pelvis does. We could see wind sweeping as part of that rotation. So we need to address then all the other body segments after we have a look at that pelvic stability. So in terms of seating solutions, when we look at some of the key ones in a bit more detail when we look at the case study, but as a general checklist, what we need to make sure is that we're stabilising the pelvis at the back of the chair. And a key part of this would be looking at transfers and that initial positioning. What might be needed to get the individual's pelvis at the back of the chair? Do we need to look at different functions and integrate different equipment to make sure that we can get the pelvis stabilised? We need to make sure we've got the correct seat dimensions, as we mentioned, seat depth, seat width. We need to set the back angle according to the hip range of movement, because if somebody does have limitations to hip flexion and we don't open up the hip angle, we'd be forcing them into that posterior pelvic tilt because we're not accommodating their range. We need to make sure that we have correct use of chair functions. We've done a whole webinar on safe and appropriate use of chair functions and accessories. So I can't go into detail about this now, but maybe we can share the link in the chat for access to that. But there are certain functions that we need to be really careful when we prescribe. Things like tilt in space and back angle recline might not be indicated for everyone. It might be safe and it might not be safe or appropriate for everyone. So we need to be mindful of those because they can actually cause postural challenges. And we also, as we know, need to support the feet adequately for that proprioceptive feedback. We could also see an increased thoracic kyphosis, especially if somebody does have that posterior tilt as well. And what we'll see is the individual presenting with an increased curvature of the thoracic region of the spine. So that top part of the spine will appear more curved than normal. And as we know, we can be associated with that posterior pelvic tilt, but also increased pressure through that apex of the curvature as well. Now, the problem with the kyphotic posture is the risk of physiological dysfunction and the impact that it can have on interaction and engagement. We need to be mindful of that function and physiological function element as well. So we need to make sure there's safe head positioning for eating and drinking, for example, open up the shoulder girdle as much as possible for good respiration. Another difficulty with this kyphotic posture is the line of vision. So individuals with quite severe kyphotic postures, suddenly their line of vision might be towards the ground, which of course will impact on interaction. There are different seating solutions that we can trial depending on the need, depending on those intrinsic and extrinsic factors and whether things are correctable, whether they're fixed. A waterfall back can be a good one for somebody with a mild kyphotic posture who still has good postural control and sitting balance. So that middle section can be reconfigured, so the wadding can be removed, and it can encompass that curvature of the spine. If somebody has quite a fixed kyphotic posture and we can't bring them to the chair, we might need an articulating back and head support to bring the chair to them. Some individuals respond quite well to tilt in space as long as it's appropriate and safe for them. So obviously need to think about dysphagia and swallow ability and the risk of aspiration. But if it's appropriate for them, sometimes it can be used to offer periods of relaxation to try and open up the shoulder girdle before coming back upright. Some people actually don't respond really well to tilt in space and fight against it, and it can actually worsen that kyphotic posture. So an anterior support can work well in some cases with a tray, a padded tray or a V cushion in front to support the upper limbs and give them the feedback and the force from the anterior position. So when we look at Alan shortly, you can see what we trialed. And then we mentioned about contractions and deformities as well. Now, this is where there's a limitation in passive joint range of movement. Now, contractures are complex because there's a number of different structures that can be involved from the soft tissues right through to the bone. And then that will dictate then how correctable things are. Now, just be mindful that somebody doesn't have to have a specific neurological impairment or diagnosis to develop contractures, because if an individual sits for a prolonged period, then at risk of soft tissue shortening. So it's all about that repositioning, regular change of position. Now, the seating solutions that play a key role with this are things like considering those critical angles for sitting and what we might need to correct or accommodate within the chair. Of course, as usual, the chair setup is important, appropriate use of functions, but then depending on hip range, we might need back angle recline. Depending on knee range of movement, we might need a negative angle leg rest, and in those cases, we might need to be very clear in the care plan that somebody shouldn't have their legs elevated. So if there's concerns about knee range of movement, make sure that those who support the individual know not to elevate the leg rest, because we'll just pull them down into that sacral sit-in. And then you work your way up to then more complex tailored solutions. And we've got an example of one here, which we'll show you on the video shortly. But essentially, we might need split leg rest to accommodate and correct both sides of the body. And then you can see the image then with the purple chair, a hanging foot rest, where the leg rest is actually taken away for quite severe contractures to be able to tuck the legs under the chair. And there might be an element of compromise here, but it allows people who might be considered as unseatable to actually sit out for a period of time. And then going back then to the purpose of posture itself, two main purposes really. So about the individual, so anti-gravity, remaining rigid and erect against the forces of gravity, so upright sitting position. But also it's really important that they have interaction with the outside world. So the environment is really key. And things we might need to consider, even simply down to the position of the chair. If an individual's main functional engagement that they want to achieve in daily life is to watch television, we need to think about how that chair is positioned in front of the TV, because we could be creating these rotational postures just from the way that things are positioned. We need to make sure that the chair integrates with equipment, manual handling equipment and so on. There's space to utilise functions safely, because obviously back angle recline and tilt displace can increase the footprint of the chair, but also that manoeuvrability as well between rooms. Do they need to access different areas of the house for hobbies, for occupation, for activities? And we need to encourage that for compliance with a piece of equipment. And then, of course, there's also the support network, because especially with complex cases, individuals with complex disabilities, we might be relying on the support network, whether that's family members or loved ones or actually professional paid carers. We still need to aim to consider them in the process, reduce that dependency, reduce carer effort, especially when we might be relying on them being compliant with care plans, and just really check in competence as well as confidence. And that's something we can support with as well if there's training needs. So just as a quick summary then, before we move on to the practical case study, what we really aim to achieve when we're thinking about the three elements of function, the step-by-step process, making sure that the chair dimensions and the chair is set up for the individual user. We're stabilising the pelvis, we're supporting the feet, we're working our way up through the spine, so through the trunk and the head, and getting that alignment, thinking about physiological function. We're managing those critical angles for sitting to make sure that we're not causing any postural challenges. We might need to consider anterior support, and then thinking about engagement and integration with the outside world as well, and how that chair fits into daily life. And just visually, just to see the difference, what we're aiming to do, you can see gravity taking hold here. I said about exaggerating asymmetries, head slumping forward, the body leaning and rolling. And what we're aiming to achieve, of course, is gold standard. But if even in complex cases, we should still be aiming for the optimum sitting position. Feet supported as symmetrical and aligned as upright as possible, but still able to remain balanced even when dynamic and needing to reach outside that base of support for the functional element. Let's quickly introduce Alan, and then we'll get the video back. I'll get us back on screen and we'll run through the practical elements. So Alan is a 72-year-old gentleman with dementia. He has Alzheimer's disease. Lives at home with his wife. There is a package of care in place, but there are concerns around that breaking down. And that's mainly because there's no alternative seating. And this is especially impacting on the safety during transfers, as he's still semi-ambulant. What they're seeing is increased time spent in bed and increased episodes of agitation, which is believed to be due to mood and social isolation. And then the key postural challenge he presents with is discomfort, fatigue because of this generalised weakness, and the risk of deconditioning because he's spending more time in bed. The pelvic instability with its habitual posterior pelvic tilt, and increased thoracic kyphosis. And then all of this is then impacting on function. So that we can see impairments in things like movement, physiology, and engagement. And of course, the increased risk of care home admission. So the main objectives is to think about postural care, think about the seating solutions to really keep Alan at home with family. Hopefully we should be back on screen.
Okay, so what I thought I would do is to look at 3 chairs from our range and take you down the journey that we took to provide Alan with a seating solution. 3 chairs I have with me today are the Hydra Tilt in space, fatigue, energy management, perfect, just what we're looking for. Seat width, seat depth adjustment for pelvic stability, again, ticks. Foot support, leg support, again, ideal. I'm just going to show you, I've got a chair with me today, which is a little bit unusual. So I just want to break away, if you like, from Alan's case study. I just wanted to show you an example of what we call a tailored solution on a Careflex chair. So I was working with a colleague earlier this week where we had a client with different ranges of movement at the knee. So we used what we call a split leg Hydra Tilt. Everything else with me today is a standard off-the-shelf component of a Careflex chair. What I've got here is that example of that tailored solution. So I can raise the one leg, I can leave one leg down. See there, split leg Hydra Tilt. Didn't really apply, well, didn't apply at all to Alan, but I just thought I'd show that to you today because I've got the chair with me.
Yeah, especially when we talk about that balance between correction and accommodation, especially if people are presenting on 2 different ways, left to right. It's just a really good seating solution to try and accommodate one side, correct the other to maintain and hopefully preserve at the same time.
So seat width, seat depth, foot support, leg support, tilt in space. The grey chair is the multi-adjust. Again, lots of similar features to the Hydra Tilt, except we now have back angle recline as well. Just showing you the chair with a tray, because the tray was important to Alan, but we could fit a tray to any of the chairs as well. Moving on to the 3rd chair, called the SmartSeat Pro 2. Tilt in space, back angle recline. Similar foot plate and leg rest to the one we have with the with the multi-adjust. It's got a negative angle as standard. The back on the SmartSeat Pro 2 is quite a complex design for those with more complex requirements. So I can adjust each back section individually. So I've got height, depth, I can twist, I can angle, and then lock that off. I can open the wings up. You can see there's a lot of adjustment and a lot of movement in this chair, but that was really a little bit too complex for Alan. And we like to go down the least complex solution. Yeah. So we discounted the SmartSeat Pro. If you want to know a little bit more about this chair, go to the website. Everything we talk about today, both clinical and practical seating solutions, you'll find links across the website for various features on the chair. That's the SmartSeat Pro 2.
Yeah, there is such a thing as overprescribing specialist seating as well. So always go for the least restrictive, and especially in this case with Alan, with his wife being one of the carers, but also the care package as well that was in place, and wanting to make sure that the care plan was simple and easy to follow. Alan just didn't simply need that level of complexity.
Simple and easy, the less to go wrong, but yep, perhaps future-proofing things. But we knew we had a good idea of how Alan's condition was going to progress. Normally for something like Alan, I'd be looking at the hydro tilt in space again, back angle no back angle recline. But the feature that we needed assistance with was a way of helping Alan, because he's semi-ambulant, to stand, to walk. The hydro tilt didn't quite achieve that for us. It wasn't quite the right seat to floor height, and the tilt, even when the tilt is upright, it's at 8 degrees of tilt, so it's slightly more difficult to stand, to walk from.
Yeah, which is great for that pelvic stability, but I think that's a really key part with specialist seating is compromise. And when we think about the holistic approach for Alan, the main thing, as Les said, was that standing transfers and maintaining that independence with being semi-ambulant and maintaining that at home. So the multi-adjust was just perfect for that.
So the multi-adjust seat width adjustment, so even to the side. See, we don't need any additional components. Arm height adjustment, seat depth adjustment, and we'll show you the impact of correct and incorrect seat depth adjustment in a second when Rebecca will join me. Key feature for Alan, though, was to help with that stand assist. The chair tilts forward, ever so slightly forward, so it brings his feet flat onto the floor. Foot plate on a negative angle means that Alan can get in a good position with his finisher.
The really key to get that stable foot placement, tuck the feet behind. So just the way we can get that centre of gravity in the right place to encourage him and give that bit of propulsion to stand up safely.
So the foot plate and the leg rest and the way that they work in this chair were key. Seat width and the seat depth adjustment. Should we have a look at seat depth adjustment?
So when we talk about the real basics then of positioning, the chair is only as good as how it's used. When we as clinicians leave that environment and the seating assessors leave after setup, this is really key in the care plan to address any training needs and make it clear how to adjust, or in some cases not adjust things and leave things as they are when they're set up. But why seat depth is so important. One, for pressure care. I mean, this seat depth is too short. You can see there's a hand width gap there. If we take 75% of our body weight through our buttocks and thighs, that's now doubled onto the pelvis. We're obviously then wondering why things like pressure injury is happening. So really key for pressure care. But when we talk about function and stability, if the seat depth is too long, it can be just as detrimental. Quite hard to do for me, but if the seat depth is too long, I don't have any damage to my body systems, but we can create a postural challenge just from the way a chair is set up, because right now I can't quite bend my knees over the edge of the cushion. So just to be able to bend my knees, I have to go into that sacral sit-in. Just to be able to bend my knees, flex the knees, I have to go into that, create that posterior pelvic tilt. We obviously naturally seek that support through our feet as well. So to feel stable and planted on the floor, we've created that posture challenge. That's why it's really key to get seat depth right for the individual.
So moving up the chair, you can see I've got the multi-adjust fitted here with adjustable laterals. Didn't quite need adjustable laterals. Found them a little bit inhibiting. We could move them up, move them down, but didn't really help with function. So what we did is we took the laterals away.
We still want to encourage, as I said, function, and we can only do that if we have some active engagement as well. So if somebody is able to be a bit more dynamic with their posture, and they want to encourage that within chair, we don't want to restrict them or be rigid with our support. We want to see them actively engage in their core, and we do that by just having a guide with a contour rather than the external lateral support.
Just a prompt,
yeah,
Alan, to sit in that midline position. We didn't want to take all the effort out of sitting, but this helped just to prompt that midline. That's just very quickly and clip back. Just click that back into place, and that worked really, really well. Comfortable, didn't inhibit function, really comfortable solution for Alan.
And while we're talking about the back support, what we found is when we were able to get the chair dimensions right, because obviously Alan didn't have any alternative seating at home, he was just used to just a standard armchair at home, and there wasn't the right setup for him. Once we actually got the seat depth right and the seat width, that we saw an improvement in our pelvic stability, which also then improved, we saw a bit of an improvement in his kyphotic posture, which was fantastic, but there was still a bit of a gap, so we couldn't bring him all the way into the chair. So that's where something like the profile headrest then can fill in that gap, bring the chair to Alan to support that remaining kyphotic posture. And then Les showed the tray earlier as well. This was actually really good for anterior support for his kyphotic posture as well, because it just gave a bit more prompt and postural care, as well as obviously the functional activities, playing cards and so on, reading a newspaper, that platform for that.
And this pretty much was the setup of the chair that we provided for Alan. The other considerations, we looked at powering the chair, so would help with his wife for care. She's frail and elderly, so that would give her a little bit more control. Not appropriate for Alan, but the chair can also be tied into an environmental control system. So if need be, we could hook this chair or any of the chairs from the range into that system. And I think that was pretty much it for Alan.
Yeah, that was the setup. And it just really shows, I guess, the difference when we always use the word holistic when it comes to postural care, because we could have gone in, as Les said, with something like the HydroTilt, really focusing on pelvic stability and postural control and having that as the main focus. But we've got to think about quality of life. We've got to think about compliance with equipment. And for Alan, for him, it was that functional engagement, not feeling the need to go back to bed, to be able to be part of the family, and to still have his independence as well. Again, that preference for Alan was the multi-just, and that's something we went with them because we could work with it and compromise and still achieve optimum positioning as well. And
we future-proofed things as well, because you know, the stand to walk was happening now, but we knew that wasn't going to continue for long. So it's really important that the chair was compliant, would work really well with the hoist as well. Yeah, compatible with future movement and handling techniques. With the overall aim of keeping Alan at home. Yeah. I think we're just about on time. We are, for a change. Do we have any questions, Jess?
Not at the moment.
No. We've covered an awful lot today. Not really gone into any detail at all on the chairs and how to adjust these things, but if you want to refer to the website, again, just click on the website, go to the search for how to, and it'll bring up a list of videos explaining how we adjust the foot plate, adjust the leg length, the seat width, the seat depth. It'll show you all of those things in detail. Yeah, there's we've also covered a lot about different terminology as well around postural challenges, but not gone into depth about assessing for them and the intrinsic and extrinsic factors and how that will apply differently to the seated solutions. So if anyone wants kind of the booklet on individual postural challenges, then use the chat function. There's a whole wealth of resources on the website, different blogs and articles, and our YouTube channel has got all our past webinars as well. So we appreciate the 45 minutes an hour isn't long, but hopefully gives you enough to encourage that further reading.
Got a couple of questions just come in. With regards to Alan, how long did Alan tolerate the chair when he first used it?
Well, we actually left the chair on trial with Alan because there was a little bit of a history of you know, chairs being provided, and just not really being what Alan was looking for.
Especially with the dementia element as well, having that familiarity and making sure that there was compliance with the chair. The trial was really key,
Yeah.
wasn't it? And with any piece of equipment, it's a really good point really about the tolerance. Any change in equipment has to be a gradual process. So you're talking, I mean, some individuals might only tolerate 50 minutes. I think we started off, Alan, was about an hour on the first day, building it up, making sure that the tolerance was there. Because it is a change in positioning. It might be a change in awareness, spatial awareness. So definitely gradually increasing that tolerance, not expecting somebody to go from no alternative seating to specialist medical equipment and tolerating 8 hours in one go was certainly a starting point of around an hour. And we were able to build that up over the week then.
With regards to widening of the chair with the armrest, is there a gap then between the seat and the armrest?
Only when you go to the seat width range is 40 centimeters to 55 centimeters. On the standard cushion, you can go up to 50 centimeters. If we want to go to 55 centimeter seat width, we do recommend a wider seat cushion to avoid those little gaps and little gaps on the side of the chair.
Make sure there's no entrapment issues. There's two cushion sizes.
How much space should there be between a person's width and the arms?
Oh, you've been getting asked this a lot whenever we do our training days. I mean, seat depth is generally unacceptable. Everyone's seat seems to follow the same rules with seat depth and having finger width behind the knee. When it comes to seat width, I come from a learning disability background. I've specialised in learning disabilities since I graduated, and certainly for the type of clients that I've worked with things like cerebral palsy. And really needing that proprioceptive feedback. The seat width we've always gone so that it's touching, so it's grazing, so they've got that support, because sometimes even just giving a centimetre of wiggle room and you'll start seeing that rotation of the pelvis. So certainly for the client groups that I've worked with, it's been a hip width, or I mean, again, we can digress on here. If somebody's got a wind sweeping, for example, it's going to be a very different measurement because we need to do the two widest points. But for somebody who's able to get thigh alignment, that hip width, that pelvis width, and having it grazing and touching, so they've got that sensory feedback. We do work with individuals who have pressure, skin integrity issues, in which case you don't really want the width of the chair touching, you just want it there as support. We also
say like a hand's width to the side, then you may be wanting to put a sling on and off, and just the positioning of the sling can cause more harm than good.
Yeah, but that's something that the seating assessors will work with you and kind of ask those questions to find out. But anything from touching and giving that proprioceptive feedback to get a hand width. Any more than that, you do start seeing that allowance for the rotation to happen within the chair.
What is an average cost of, say, the multi-adjust?
The average cost would be about 2,425. That's 2,500, 2,400.
Thank you. I think we're okay at the moment with, we had another one. Do you have any examples of experience of people using head switches for communications and where they could be positioned? Yeah,
sometimes I've not got, I mean, the headrest we have with us today, well, there's a couple of options. Our soft cushion headrests, we do like a foam block headrest as well, which is more sculpted and more solid. So quite often then that gives us an opportunity to
foam is a denser foam.
Yeah, to mount a head switch. So we can just come across, or on something like the Smarty Pro 2. So we can bring one of the wings in without, or bring it in closer. We can attach something in here then just to make contact with that switch.
I guess the nature they're having chairs manufactured here in the UK in Devon is that we do have the scope of, obviously mentioned about tailored seating solutions as part of that design and engineering process to be able to tailor and integrate communication aids and stuff into it. So yeah, we have done it. We have seen it.
Yes, tailored solution,
Yeah.
bespoke solution to a postural requirement.
Great, thank you. I would just say that a lot of the links to some of the resources are in the chat function. So if you want to refer back to any of those, there is a Pocketbook link that you can click on that we will post you out a Pocketbook. And the postural challenges is a PDF download at the moment.
And everything that we've covered today, I'll put a bit more detail into the PowerPoint. It'd be a reference list on there and a bit of information around the case study as well. Our contact details will be there, so if anyone thinks of anything client specific, after you leave or after you do a bit more further reading, then yeah, just get in touch.
And I can see people are asking about the PowerPoint. Yes, we will be sending out a copy of the PowerPoint as well. Is that it, Jess?
Yes, I think that's all for now. Yeah.
Okay. Well, thank you for joining us.
Thank you very
We
much.
hope to see you soon sometime, and take care. Thank you.
Thank you very much.
Bye-bye.
Bye.